So we will go to the roundtable for open general discussion. We have quite a bit of time to do that, and I'm sure I'll be reminded when my time runs out. But if you can go to the microphone once again, remember we are on webcast. Please identify your name and for the appropriate attribution. Katina, I am going to come back to you later about that issue of health literacy and insurance. I'm not going to let you get away with it because I think it's a good topic for us to have a discussion about later on. Ruth?
Thank you guys so much. Ruth Parker. So I want to push you guys a little bit, not in a paragraph, but in a sentence, to tell me what the public needs to understand and know right now about the privacy and data of electronic health information. What would you like to tell them right now?
Read the privacy notation in it. No, that's it would be nice if the people that wrote how we're going to use the data did it in a very simple format, which says we're going to do this, this, and this. We will not do this, this, and this. I actually have gone through several of the Apple Research Kit products, and that was done pretty well because there are choices. You go to 23andMe, and they use that data in all kinds of different ways. So, everybody's going to be different, and it ought to be simple to understand how it's going to be used and how it's not going to be used.
I'll mention that this will be the topic of a presentation this afternoon that Allison Rain will be given. So I think a few responses, but we'll have a lot more time for discussion on this exact topic. Does anyone have something they want to add to it at that point? Okay. I promise you we'll get back to it.
Remember just to identify yourself, Michael.
Yeah, Michael Pasha-Orlo. Thank you very much. There's so many things here to get into. Just a few reflections and then a quick question. Intuitive design, that sounds great unless it's not intuitive to you. Recently, my mother was discharged from a hospital, and she said her face was swollen. I said, "Dad, send me a picture of this right now." And he's like, "How am I going to do that?" I said, "Well, you have a smartphone in your pocket. I gave it to you 2 years ago." He's like, "Okay." "Well, that's a camera." Okay, so, he went to Harvard Law School. He's still practicing lawyer. He happens to be 80 years old. And so I had to walk him through the concept of sending me a picture. And so I finally got him to do it. And I said, "Dad, what do you see right now on the screen?" He said, "I see the whole room." Okay, because, so eventually he sent it to me, and my head almost exploded in the process to try to get him to do this. And then, I called him back, and he said, I described what I thought I saw in the picture. He said, "You got the picture?" Anyway, so intuitive design is intuitive to you. You have to actually find your target audience, understand what they can do, what they're doing, and figure it all out. Okay. Another thing is, my hospital is undergoing EHR change, so I just did the training. It's going to be a full day-long training. I only did half of it. My head almost exploded. I think we've got to be much angrier than we are about the fact that there's not interoperability, the fact that the data is not going around. This is actually something that, despite Rob's earlier endeavor to get himself no longer have a job, but to have government out of regulation, actually there's a huge space that government has to play a very strong role in, because it's explicitly not in the business model of these organizations to have interoperability. It's going to have to be forced on the system. And so actually the data has to flow much, much better. And I think history will look back at this time and say we've squandered a tremendous amount of opportunities, tremendous amount of money, without actually the data flowing around the way it should be. Everyone's going to drag their feet until the data can be interoperable, and that's going to have to be forced on this. And people should be angrier. Anyway, stop. But now to this stuff. I think the question is this. So the question is this. I think it's very important to focus on knowledge and information exchange, but really people are not going to use that app unless it makes their life better. And so the issue is going to be function and what it can do for you. Can I make it so I don't have to go 10 times this month to the pharmacy? Can I synchronize all my medications to get picked up on the same day? That would make my life much better. Why can't the thing do that? Can I make it so that I can, there's so many things that can make people's lives better. So there has to be a marriage between the concept that this has to bond with that the healthcare system is a service industry and all the things I think much of what we're doing here is about knowledge transfer, which is great. But really, it's got to be about function. So maybe if people can talk about where this goes, because I don't think that people will use the app long term, any app, if it's just about knowledge transfer.
So I think even more so than does this make my health better, we know that people use lots of apps all the time, and it has nothing to do with their app and doesn't improve their quality of life. And to the contrary, we see kids wasting time using games is a perfect example. So what is it about that functionality that's making something that's sticky, as we call it oftentimes, to draw people to use it? So I think information transfer doesn't work anywhere. We know that in the classroom setting, it's boring. Kids don't like to sit there and they don't learn anything. So again, it's just thinking about what is it that the functionality that our end users do need that will help them continue using whatever the app is.
So I was going to say, for us, the functionality making life easier that's actually been one of our key focuses. The idea is how do you make your prepare for your visit and make encounters a better use of your time. And we've seen it come into play, too, where, I mentioned before, people get invitations to go and enter information to share with their doctor, and they don't do it until after the visit. Sometimes we're seeing, I was asked this over the break, sometimes we're seeing this as a reflection that they're realizing the value after the encounter, or we're seeing over time it's changing where the doctor will say, well, why didn't you do that? If you did that, it really would have helped me for making your visit easier and better. So I think that's a key point that you bring up. I think one good thing as well, the number of apps that are out there is probably great that there's a ton of them. So, every app doesn't have to work for everyone. So there's different things that will work for different people, and that's probably a good thing. And then the data standardization that you went off on, I think that's a massive issue. We've had gigantic problems with that on our end. And just taking preventive care as a framework, a lot of the standard data transfer through the CCDA and other aspects, they don't capture all of preventive care. And they really don't capture the patient-reported elements of preventive care. So we've got some massive work we need to do around standardization and sharing of information. So those are good points.
So Dean, isn't it the story arc that actually creates the cultural change by then putting technology into play?
It certainly helps because
Does
with
more than
my
help.
parents that live on a rural area in Vermont, he has a smartphone, he has a laptop, but I can't get him to use it either. Telephone works pretty well, and the remote control does. So, unfortunately, there's going to be large sections of the population that need it most that grew up in the living room with the radio and the analog dial. And unfortunately, when you're young, the user interface that you learn on is kind of what you stick with. So we're going to have a problem because many of the chronic conditions are 65 to 85. And that's just the way it is. I think there are things we can do. I think if we looked at the whole reimbursement system differently, if healthcare systems said instead of building another building, we're going to start thinking about remote technology and putting technology that's usable by the elder population that we have to serve in their homes, it's a whole different economic process that we've got to do. But most hospital systems talk about the MRI machine they're going to buy, the new wing they're going to build because somebody donated the money that wants it on it. And until we start thinking about the software investment, which is people and experiences, we're not going to get there quickly. Well, what's fortunate is that we've got baby boomers that are on that cusp of being able to learn this stuff that in 20 years are going to really need this, and they're going to be equipped. So it's going to take some time.
Terry?
Terry Davis. I have a question for Dean. What can you teach us about icons that made them intuitive. Now, I know they're not intuitive to everybody, but Apple did a really good job of making some things intuitive, and we're trying to do a better job with labels. And with health literacy, icons are important, but people have to get what you're trying to say. So what can you teach us?
Well, the first thing is that maybe you don't need an icon for everything. Words, if they can read, that is a good thing. Like on the Apple Research thing, there's a button that says next. Well, I got that. So sometimes we icon everything, and it's not always easy to create an icon that communicates across the board.
Like for external use only, what's that?
Yeah, right. So one of the things we've built into our system is that everything you tap on the phone, we record. And so we know if they looked at it or not, if they did the next behavior properly or not, et cetera, so that you can actually learn. So part of the design process is the iterative. And because we're using Google App Engine and we got big data query, we can start doing the crunching on those issues, getting it right down to that issue. So, sometimes words really work well. And sometimes words plus the icon. And maybe you need to use that in the first 2 weeks of the experience, and then you can drop the word if you want to. So,
Right, so you need to teach them, and the word can somehow prompt the icon.
right. Or it could be a sentence, or, every time you do this, you're going to see this, and that means something.
Can I add to that? I think there's a middle layer between icon and plain language, and that's jargon. And so if you're introducing a user to a concept for the very first time, very simple 6th grade level words are the best way to convey that to anybody and everybody. And there's a very big and difficult process that brands go through all the time, where, they've got the name and they want you to remember their name, and then over time, I think about Starbucks. I don't know if you remember the lady that the Starbucks, and she used to actually be like zoomed out more, and there were wings behind her, and then Starbucks is slowly but surely like simplifying their logo, but they sort of have to train their users to be like, oh, that lady equals Starbucks. So there's a mental translation between sort of that icon or brand and the very plain language. And I think where we often, sort of the quote unquote experts, get stuck is actually in that middle layer, where we try to use words, but actually we're using jargon because it's like a shortcut for us to mean something that through more words could actually be in plain language. So I thought I'd just note that and it just reiterates his point.
Lori?
Well, thanks everybody up here. This has been an amazing day. As
Just
we were saying.
identify yourself.
Oh, sorry, Lori Francis, Oregon. But I really appreciate so many of the comments that have come from everybody up there, really the whole gang. That idea of training provider teams, and I would add the word team every time we say clinician team. We know that it's a team, not a person anymore. And in fact, the consumer is at the center of that. And I think sometimes with end users, we forget the end user is actually the consumer versus us, the clinical team. So I appreciate that. And my question is about the private sector and capitalism as a driver compared to government. And thinking about the group that is most predisposed to poor health and shorter lives and less good lives are those that we're talking about who experience many challenges. And I'm thinking about all of you, and like Dean, I'm assuming you guys go into East Palo Alto and ask those households, but do you? And then there's the trust issue, and there's so how do we get, I guess you guys think about this all the time, is capitalism isn't looking for the consumer that has no money, I believe. And I think that's where grants come in. So I'm just curious how these things come together, where we create products for the people who are actually most predisposed to poor health, and there isn't a big money gain. So how does that happen?
I'll give an example. We're working with a group that provides, in-home dialysis, clinic dialysis, et cetera. And many of those people have had diabetes and failure and in low income. And those cost the government $60,000 a year just for the treatment. And to get them to be able to stay in their home and do the treatment is actually less expensive because you don't have those things. So we're looking at ways to say, all right, well, there's a pile of money that's getting spent that allows us to create an experience that makes the life of a person better, yet saves the government money. And that's what I was talking about as far as the restructuring is you need to figure out the reimbursement piece and then attack that to say, well, there's money and how can we create a better life experience and lower cost? And that's where technology can come into play, and also engaging the community and family members as providing part of the care that you'd otherwise have to go pay to get done. And I believe as Americans, we do like to serve. We want the opportunity to help. And we need to figure out those roles in that care team to do it. So, and to get back to the privacy issue, in a pregnancy, the first trimester, it's a secret, right? You might tell your mom that you're pregnant, but no one else knows because... And then this next one is the family and the friends, the third trimester, you've been going to the doctor's office and now there's other women, and so the network changes, right? So you have to be aware of that, and you have to be aware of the role of the spouse, the friend, the community advisor, the doctor, the nurse practitioner, and each one of those need to have a unique view into the world of the patient.
So, Lori, let me add to your question a little bit, and maybe I'll ask Alex to answer this. How does the healthcare team for the physician find enough time to do all this?
There isn't enough time. Wow. So, and that's some of the promise and the allure of technology. So, as an example, some of the stuff that we've been trying to do and some of the value of being able to integrate this into the care setting is that we use the content that's coming in from the patient experience and from applying clinical and patient information to guidelines to create standing orders for practices. So this fits in with the team functionality, fits in with population care, and we're able to get, even in some of our practices, secretarial staff to be able to call up patients and offer them preventive services. So we've actively been trying to shift who is doing activities within practices, and that's been part of our strategy. Because I think, and that's where I also put the appeal in earlier for evidence is, well, there's more work. We already know there's more work to do in the healthcare settings than can be done and in the community settings. And so we want to make sure we're doing the right stuff, and we want to make sure we're building partnerships. And so a whole area that's not been built out, and we've tackled in some other ways, but it's also linking like the healthcare setting with the community setting and these other areas. So I think there's lots of untapped opportunities where promoting health literacy, building teams, sharing information, and creating partnerships can really change what we can do.
Hi. Oh, go ahead.
So, I would be remiss if I didn't mention the Blue Button connector site. I know Reed touched on Blue Button, but this is a site that we've created that means to be sort of a one-stop shop for consumers to really understand their legal rights to their electronic health information, but also what to expect. How can I better prepare myself for a conversation? The site was just launched last September, so it's fairly new. But we have now, I believe, over 600 different pledge members that have, showing us the commitment to open data and to giving consumers access. It's a place where they can find out about different apps that are on the market now, different tools, and just how to aggregate and manage their health information. So I think that's just something I wanted to mention as a way of consumers being able to maybe better prepare themselves for those conversations.
Hi, Laurie Myers, and I'm a Roundtable member from Merck. And first of all, I wanted to echo what Laurie said about it's just been a great morning, so thank you very much. The thing that strikes me is that we have an obligation to think differently about the system and reducing the complexity to enable disparate populations to take advantage of these things. And I had two thoughts and just wondered, wanted the perspectives. So the first is, I think you talked about the universal gaming that has been successful across all populations. And I myself checked my smartphone, checked my email, and played Words with Friends before I got out of bed this morning. So I'm there. But the question is, are there lessons from gaming that might help us as we think about how to make this more universally attractive? So that's my first question. And the second question is, we've talked about, an MA, informatics. We've talked about the importance of the team. And of course, payment models are slowly evolving from fee-for-service towards value-based payment. And I wondered if you had any thoughts on, does that create an opportunity to help to address things like pedometer and instructions, right? And, what influence might that have? So thank you.
One of the things we learned from the gaming industry is that many of the games are very modular. And when they decide to add a new feature, they snap it in and literally give it, 2 or 3 days of test run. And if people use it, great, it stays in the game. And if they don't, they yank it out. So that's one thing is you just got to be able to try it and measure it, right? And that's a big deal.
I think the gaming piece is indeed interesting, and we've talked a little bit about experience, and games are just wholly immersive, and I think that you contrast that with like Pride and Prejudice. As a book, there are a lot of people like us that love reading lots of words, but there are a whole lot more people that actually would rather be playing a game, and it's the part of it is sort of it's an interesting combination of like the passive information while being incredibly mentally engaging. So reading words on a page is mentally engaging, but it's like really, really hard, right? So I think from a design perspective, sort of making information available through that immersive, again, sort of experience, I think is indeed important. You mentioned incentives, and I think that is a really, certainly an astute point. We're in such a fascinating time in the healthcare, really just sort of in society at large. Obviously, the shifting changes in incentive payments are creating massive opportunities, and I don't think that there really has ever been a more exciting time, and I think the opportunities are incredibly significant. From a strictly like capitalistic business perspective, it's not like glowingly awesome. I'm not going to like transform and heal all American citizens overnight, but I think the trend is good. You juxtapose that with the incredible pace of technological change, and not just how technology is changing, but how cheap it's getting to be able to do things. Apple actually right now, we mentioned the price point earlier, Apple is making a very deliberate decision to position themselves sort of into the high-end market because they know that the technology is going to get cheaper and everybody's going to be going that route. So I think that's actually a really strong indication that they're like, wow, this market is going to be available to everybody, and we actually have to position ourselves to a certain customer base. So I hope that helps address some of your questions. I think that all the trends are good, and it's a very difficult, complicated time right now, but I'm really excited to see where all this is going.
Just to build off of some of those comments, I think it is a really exciting time when you have so many different factors coming together. I mean, you're seeing more consumers, accessing their portals, understanding, trying to understand what it means to be able to use their health information, to aggregate it, using apps that do this for them. But I think that, we're coming from a place where we have very perverse incentives. Let's be honest. I mean, it's competition. Why would I, as a hospital network, share with my hospital network down the road? Why do I want them getting my patients? And that is changing. I think that that's exciting to see. Some of the new payment models that, like you said, are moving away from fee-for-service. I think that we're seeing, through open notes and a lot of different initiatives that more and more people are using across the country, data is opening up and data is flowing, and it really needs to flow. But I think consumers play a big role there. You know, if we're going to get to interoperability, we need more end users in the system and more people demanding for it to change. You know, we talk about having data when and where I need it. That is what interoperability is, the bottom line. And so I really think that, you know, we are seeing that shift, but the more consumers can actually ask for it and say, well, I need this to happen. You know, I need my doctor across town to see this information. Why can't it happen? And that's a really great question.
Yeah, I was going to say one other thing about the payment changes, because one of the other hats I wear is I direct our university's practice-based research network, and we have 300 practices that all work together in eight health systems and everything that looks like primary care. And there's a lot of changes as we think about accountable care organizations. So in Virginia, we now have 12, I think is what we're up to with accountable care organizations. And health systems and practices are scrambling to hire people as care coordinators and case managers and patient navigators and trying to shift the cost curve. And there's an opportunity for information to play in that. There's a real lack in that from a practices perspective. And they don't know how to do this. And I think it's something that everyone is learning. So with the boom of technology and then learning how to redo things to better deliver higher value at lower cost for care, it just creates some neat opportunities.
And one of the other things I've learned is sometimes the care coordinators, depending on the level of education, can have health literacy issues themselves.
Oh, yes.
Right?
Yeah.
And so how do we think about that and put that into context as we create things to help them? So thank you. Thank you.
Hi, good morning. Wendy Nickel from the American College of Physicians, and thank you, Dr. Rosa, for talking about the time issue, because that's something that I worry a lot about when I work with my colleagues at the ACP. So I actually wanted to defer to you for a moment and ask you how long it took for that interaction with your dad and trying to guide him through the camera and sending the picture.
Well, I stopped it at 45 minutes because I was almost going to have a first aneurysm.
So the reason that I asked that question is because I think time in the individual physician-patient encounter is really, just something we have to think a lot about. What I worry about is also the fact that you talked about 40,000 HIV apps. Is that not accurate?
40,000
Health apps, I'm sorry. But the number of apps that have to be distilled by people to figure out what's appropriate for them, and for a physician to have time to do that, or a healthcare clinician to have time to do that, is relatively impossible. So I guess my question is, how are we as an industry going to guide our clinicians to find appropriate apps, find the appropriate technology to support their patients in good shared decision making, and where do we go from here? And then I did have a follow-up question with regard to patient-centered medical homes, but I'll hold off on that. So, anybody?
So I think it becomes a question of, are you as a physician, clinician team searching through these 40,000 apps, sifting through, and probably finding not too many good things out there. So I just did a review that's published in the American Journal of Infection Control on the apps that are currently existing for healthcare-associated infections. And there's a total of 14 apps, I believe, 19 apps. And when we look at what's the functionality of them, so is it just providing information versus is it communicating, is it giving the provider some feedback? Of those 19 apps, 18 of them are only giving information. So that's the same thing as you picking up a book and reading what are the current guidelines on healthcare-associated infections. So I think when we think about 40,000 apps, and I've only done the review of the healthcare-associated ones systematically, so I can't really speak to all 40,000 of them, there isn't a lot of depth and richness out there of what's existing. So I think it's stepping back to the beginning, and when I get feedback of, oh, there already are so many HIV apps, there's already so many medication adherence apps, so we know that technology can be an enabler for helping people change their behaviors, but we're not developing technology that is an enabler for changing behaviors. So starting again from the drawing board and including our end users and our providers and our our whole care team so that we're designing technology that can actually help people help themselves.
I was just going to point out that we'll do a little bit more on this topic this afternoon when we hear from Patty Dykes, who's going to talk about some of the clinician competency in the context of these tools as well.
Thank you. I also just wanted to make a brief comment, and that's of our membership, 30% are still in solo practice. So even though we're moving more towards patient-centered medical homes and medical teams, that's not the entire universe. So for these practitioners that are in solo practice and don't have time to sit down with their patients and go through apps, we have to worry about them too. So thank you.
Hi. Adriana Arcia, Columbia University School of Nursing. Dr. Bakken and I have worked with an interdisciplinary group on a project called Wiser that includes a large household and community survey in Upper Manhattan, Washington Heights and Inwood. Largely Dominican population, fairly low levels of health literacy, although we do see variety there. And what we wanted to do was return the data to the participants from the survey, but we wanted to do it in a way that could be really actionable and usable. So we have been working on developing infographics to help people understand the patient-reported outcomes. And it's been an iterative process. We did iterative participatory design with the community. And the reason I'm bringing this up is to answer your question about icons. And we were quite surprised by what we found. We tried to do all kinds of things. We developed all kinds of different graphics using icons, and they were largely unsuccessful, especially anything that used repeated icons to represent multiple instances of any particular thing. Like, these are the number of fruit servings you ate. These things just really did not work well. I think it's, maybe in Europe, where there's more use of iconography in the general culture, maybe it might work better, but in this community it did not work very well. It might just not be a very familiar concept. But we did find a couple that worked really well. This one, because we've been trained. And what have we learned from games? The games train us how to recognize the icons. So we've been trained how to use a 5-star rating system. We've been trained on how to, and if you haven't learned this, you learn the hard way. We've been trained how to use this icon. Yeah, I mean, because there are consequences to not learning how to do this, and so that was one of the things that was really important, was that I think if the icons are really ubiquitous, if we've been trained to use them, then they're going to be successful. But other than that, we found that people took things so literally that if you showed them, 3 apples, people said, "Oh, Victor eats a lot of apples." There was not a lot of generalizing going on. So that was one of the really useful lessons we learned. If you're interested in seeing more of the graphics, I have some if you want to look. I'm interested in talking to anybody who is working on making visual representations of information. But my question for the group is, what kinds of assumptions have you found that have not panned out? And we thought, icons will be great. We'll do all sorts of stuff with icons. And that really did not pan out. And I want to know, what kinds of assumptions do you find in your area of expertise have not panned out that you want other people to know about?
I have one, and this is going to be sort of a government framing answer. So we run various contests, challenges, sort of the a la open innovation. We release data. We say, hey, build the app for blah, 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 and we'll give you money. And we actually, I think very early on in this movement, this was 5 years ago, sort of when it really started to pick up within government, we thought this was going to be sort of the answer to sort of the dearth of health apps. out there, and useful health apps. And we thought, like, oh, look at us spurring the economy and the marketplace out there. But actually what would happen is that someone would build the app, they win the prize, and then they'd go somewhere else, right? So one of the assumptions we had was that the app, that we were creating actual business incentives and it's not like overly complicated. When you think about it, the incentive was just sort of to build to that initial price. So it's actually a struggle sort of in the world of open innovation to how to build sustainability into business models and help things go further, and we're still trying to figure that out.
My answer to that is prototype, and prototypes can be all kinds of different things. One of the things that we do is actually create a storyboard, much like a movie script, where we describe the person, their family life, where they work, and sketches of the daily sequence. And then we go show it to people that we think we're targeting and say, is this the way it is, as the first layer, right? And many times you just are completely out to lunch, you throw it away and you redo it again. But the point is, do it as fast and as cheaply as possible, and you learn. Because otherwise you can build this whole thing and you think you've got the Taj Mahal in it, it's just not going to cut it. So figure out how to learn fast.
We have two more speakers at the microphone. I just want to be sure we have the appropriate questions before lunch. Wilma?
Hi. Hello, everyone. Wilma Alvarado-Little, IOM Roundtable member, Albany, New York. So I have a couple questions, comments. Well, definitely, first one is, could be taken either way. So we've heard a lot about, the accessibility of the app, right? And to me, my sense is almost that we think that accessibility equals convenience. And then, Michael gave us the example about taking the photo and, all this other things that could turn into a whole other picture of margaritas. But so, my phone will go ahead and update, right? Because I have an iPhone. It went ahead and updated, and on there showed up an icon about health, something or other. I don't know. It's sitting there. Okay. So I'm thinking, so we want to make things easier and accessible, but for who, right? So for who? And so sometimes these situations can be experienced by the individual as overwhelming, but might be interpreted by the recipient as non-compliant. So how can we help bridge that communication? I'm just saying. All right. So the second one is, and again, issues of trust in all of this, because really, where's that data going? I mean, if somebody asked me, Wilma, to win the lotto, explain how the cloud works, not going to happen. Not going to happen. All right. So then my second question is more regarding your research, Rebecca, where you're talking about the 5 focus groups, and cycle 1 was a relevant cycle. And there was one group of Spanish speaker and then one group of Latinos. If you could just clarify that a little bit more, because my sense is that might not have been clarified. And so my other question is, was the information from the Spanish-speaking group going to be utilized to inform the development of an app in Spanish? Or perhaps in any other languages, because I know, Alex, you had mentioned that's one of the next steps that you're looking at. So I'm thinking, what about our communities who are vulnerable, who you gave them every app in the world, and unfortunately speaking louder and slower to explain how an app is going to work in English isn't really going to cut it. And also to our deaf community, how would they be able to access some of these resources that are available? And perhaps this is a discussion for later in the afternoon, but I wanted to put that out there. Thank you.
So just to clarify, so there were 2 groups of Latino participants. One group were Spanish speakers and one group were not Spanish speakers. In full disclosure, our original proposal was to do 2 groups with Spanish speakers, and due to recruitment difficulties, and we have some hypotheses on why people who are probably less acculturated and more those who are still true Spanish speakers are probably less likely to disclose their status as being homosexuals. So that's sort of our hypothesis on why that was the case. What we did find was a lot of congruence in our findings between the Latino groups and our other groups. Although I would also say that I don't remember the exact numbers offhand, but our participants were largely African American and Latino, and again, we were finding a lot of the same themes that were emerging across all 5 of the groups. So yes, ideally, I think that we would like to build the app for English speakers and for Spanish speakers, but I don't think that the content would be very different.
And I'd like to address the other point about who's using apps and who's not and why. I think that this reminded me of a conversation I've had with a couple of providers that we've worked with quite closely, some who have been involved with our regional extension centers and health information exchanges across the U.S. And one point when and it also kind of applies to assumptions, one assumption that I think they were making, and I'd love to hear your reaction to this, is that, well, consumers don't want this. They're not interested. And, they don't, we offer them, access. They don't do it. But I think what the providers have said is, let's take that a step further and let's look at why they're not doing it. What is it? And are we saying there's no consumer demand? Are we saying they're not interested? And are we artificially suppressing that demand by some of our workflow, some of our processes, some of the really, really cumbersome ways maybe they're having to access their data? So that just kind of, I think, speaks to really getting at why, are we creating the right apps? Are we designing them for the end users in a particular population group? And if they're not using it, why? But really getting to the heart of that, I think that's a really important point, because when you look at who's accessing the data, I think we cannot say one way or the other, well, consumers want it or don't want it, if we're really not looking at the whole picture and what that experience is when they're interacting with their primary care physician, with their whole care team, and within their EHR or their portal. So
I want to get to our last question.
I was just going to quickly respond to your question. And I think we actually have had some data where we have a good number of our providers who say, oh, my patients aren't going to use this. And then something happens and clicks, like maybe a couple of their patients just go and use it on their own, and then they start changing their mind. And suddenly there's this avalanche where they didn't realize there was this demand. But I was even going to throw on, too, the converse to that, too. We should probably add to our patient-centered IT model. I mean, the first step is patients get to choose if they use things or not. And that can be tough for quality measures for docs if you start getting dinged because your patients aren't doing something. But maybe that's okay if they choose not to do it. But I think there is a big barrier among providers and health systems who say, my population won't use this. And sometimes that's proven wrong, so.
Hi, I'm Erin Kent from the National Cancer Institute. Great panel. Thank you, everyone, for being here. I would like for some of you to reflect on the social and human connection element a little bit more when we're, talking so much about patient and user-centered design. And I'm thinking about 2 things. One is recent research that Amy Abernathy and colleagues published on how the presence of having technology, say, in the examination room actually tends to either really improve a patient-provider encounter if the provider's sort of baseline communication quality is already high. It can actually it the social connection, the communication that goes back and forth between the patient and provider, if it was already sort of low. So it serves as a catalyst. I'm also thinking about, for any of you who have exposure to young children and have seen Big Hero 6. I think a lot of the appeal to that, giant home healthcare aid Baymax was not so much his technological capabilities, it was his personality, right? It was the fact that he was so warm and loving and kind. And so I really think it's important for us to continue to come back to that human social component. We know from things like automated symptom reporting systems that it's critical to have the ability for patients to access an actual live human being on the other end of the phone and not just recordings. So as we move towards a system that is more value-based, how do we think about really using the technology to become more efficient so that we can save some of that time, not necessarily to just see more patients, but to, actually activate that human social component that patients, I would argue, all of us actually really need.
I'll start. Humans are we're an incredibly social species. So I really appreciate your comments. And I think actually it's probably the right question to wrap this whole thing up. Because at the basic, one of the fundamental tenets of interacting with your customers is talking to them and being able to have meaningful conversations and being able to communicate in a way that works for them and ensuring that they have a particular understanding of and a framework that they are approaching the conversation with so that you can have meaningful dialogue and you can build things. And that's true whether you are talking about building an app. That's true whether you're talking about teen pregnancy prevention. That's true whether you're talking about the March Madness. Like all these types. Like communication is just incredibly important. I do think you contradicted yourself a little bit, and you referenced Big Hero, which I actually saw on an airplane recently. I didn't pay for it, but the person next to me paid for it. So I didn't have the audio, but I saw sort of his. I got to watch it, and he was I don't know if robot's the right word, but it was an incredibly personified machine, and there are incredible examples. Actually, I think a lot of them are coming out of Japan of robots that are being used to help care for, in particular, the elderly and those that are homebound. And the design of these robots is all about building in that personification, that human element. And so you mentioned the need for a human connection, and I do think that is sort of the ultimate and the ideal. But the technology space is not necessarily running towards, well, how do we always get humans to interact with each other, but how do we build in the human components and sort of the personification of human quality so that you could build meaningful relationships so that they have the framework and really it comes down to the level of trust that the information you're providing is actually useful and meaningful.
And that also, I just want to make the point that, sort of taking it a step further with the human interaction and communication being so key, and obviously time being of the essence as well, we are finding pockets of hospital and provider networks that are really finding innovative ways to integrate social data into their EHRs. They really want to show that person in the limited amount of time that they care about them as a person and their, the holistic experience. We know that if a person comes in and they don't have a job or they're looking for a house, their health care really is lower on the rung of their important priorities. So I know, and we highlighted this last fall in some of our meetings with some Chicago-based organizations that are really making that sort of database of community resources available to physicians very quickly, so that they can put their clients in touch with different people, make sure their patients get some job resources or housing resources that they might need very quickly. Dr. Robert Czar here in DC started Park RX, which really connects his low-income and immigrant populations at Unity Healthcare to to parks that are near their home, so that he can actually prescribe some of these activities that they can go do, with his, he's a pediatrician, with his children, and really connecting the family. So I think that those are some examples of how, we're really bringing the human element into the exam room in the clinical setting.
Dean, did you want to make a last comment? I saw you just grabbing for the microphone there.
2 points. One is a story, and the other is where I'd like to see it. When I mentioned that our system allows different views into the patient information, my dream is that a doctor with a tablet before they walk into the exam room can look at that patient's, whatever they did the last 2 weeks, month, whatever it is, distilled down into the important data that the doctor needs to know, and go, wow, Martha did 8 of the 10 things I asked her to do. She didn't do these 2 things. I'm just going to spend time on those 2 things instead of collecting all that information, right? And then also something about Martha's kids or whatever was mentioned, so that when you go in there, you can focus on Martha and what you want her to do. I recently had a tear in my retina, and I just love all this technological stuff. They went in, laser stapled it around it to keep the water from getting in back of the retina and all this cool stuff. But when I first engaged with the doctor, he said, wait a minute, and he sat down at the computer. He was back to me, I'm sitting in the chair, and I'm like, wanting to ask these questions. He said, just a minute, I got to, And so I was like irritated, like I'm in the back of the guy's head. And then I realized, all right, if I'm going to get this, I need to engage him. And I said, well, how long have you been doing this? He said, well, it's been 20 years. And his specialty is using lasers to repair retinas and all this. And that's really fast. So how does this actually work? And could you draw a picture of my retina? And what was the actually tear? And I mean, because it's up here, I'm going to see a shadow down here. So we engaged completely in his expertise in stuff that was important to me, right? So the doctor needs to understand that some people could care less about, it took 87 laser zaps to do this, and they just want to know when is the blood going to clear so that I can see, right? So, but if the doctors have the time to engage and some training, I think they will get effective at it. But right now, they go in there and they got to ask these questions. They got 15 minutes, and they get 1 minute at the end to say, oh yeah, and eat your broccoli, and then you're done. So
Did he turn around?
he did. Actually, I came to him,
Terry,
and gave him the back of my appointment thing with the paper so that he could actually start to draw.
So what I hear is that one of the most valuable attributes in the doctor-patient relationship or the healthcare team-patient relationship is trust. And that means patient-family-centered care, it means shared decision-making, it means all the things you just said. So the question is, and we're not going to answer it now, but maybe we can get to it later, is how can technology build trust? And I think we have to think about that because we can't lose the trust piece, which is probably part of the time piece. With that, lunch will be...
The speakers and roundtable members go to the west court. There's a cafeteria on the floor below that you access on the other side for everybody else.
So thank you very much. This has been a splendid morning. Thank you to the panelists. Thank you to the moderator. And we'll meet again at 1 o'clock.